Hello, this is Dr. Maite Sandrin from Spartanburg Regional Medical Center, Diabetes and Endocrinology Division. Today I'm going to talk to you about type 2 diabetes mellitus and patients who need to start insulin. Now, some of the type 2 diabetes patients in your practice may actually be truly type 1 diabetes patients. This is called latent autoimmune diabetes of the adult. Mostly that's the category when they look like they're type 2 and truly turn out to be type 1. The talk isn't going to be about those patients, but certainly some of those patients are going to be included. Now, practically speaking, when you have a brief visit with a patient, you need to get to the bottom of things. And if you need to start insulin because their diabetes is very poorly controlled, such as fasting blood sugar over 250, a lot of polyuria, polydipsia, glucosuria in the urine, ketonuria, an A1C, persistent A1C over 9%, those patients really need to start insulin. In very few cases would you make an exception to that, especially if you've already tried several things and that have not worked. From a diagnostic perspective, I like to sort out the patients as to who are the type 1s masquerading as type 2 and who truly is the very insulin resistant patient, because for the long term, your plan may change for the type 2 patient, adding insulin sensitizers, and for the type 1 patient, maybe considering insulin pumps and other things that would be more practical for them. So what do? You get a C-peptide level. Now, you want to get a C-peptide level when the blood sugar is between 80 to 180. Because if the C-peptide happens to be low or undetectable, you don't want to just jump on the boat and say, yes, definitely a type 1, because if the blood sugar happens to be low that one day that you checked it, they were having a hypoglycemia, well, obviously their endogenous insulin production is lowered because of the hypoglycemia. That's naturally what happens. So that does not count. The blood sugar needs to be a minimum of 80. And if the blood sugar is over 180, and the C-peptide happens to be on the low side, that may be because of glucotoxicity. Now, truly, glucotoxicity tends to occur much worse when the blood sugar is higher than that. And it's relative. So the C-peptide may decrease in response to glucotoxicity. Gradually, not suddenly at 180. It's low, but it certainly can start to go down over 180. And so ideally, you want to check between 80 and 180. Also, if you're trying to get a patient on an insulin pump, they're going to want to see a blood sugar between 80 and 180. Some insurances, not all. But anyway, if the C-peptide happens to be high, it doesn't matter. You know for sure that you have insulin resistance. Okay, well, anyway, moving along. Most of your patients are going to have a high C-peptide with insulin resistance, because that's just how it goes, a great majority of them. Ask about what is new. Is diet new? Birthday recently, they went on a road trip and they had to eat different places, different restaurants, fast food places. They went on a cruise, anniversary, all those things that patients use as excuses to cheat on their diet, and then it doesn't change because now they tasted the food that they're addicted to, and the diet persists. Recent stress like infection requiring antibiotics, a new chronic diagnosis, they have new pain, new emotional stress. Unfortunately, when someone passes away, close one passes away, that can cause hyperglycemias. Also, less care for yourself. The use of steroids, not counting when you're using the adrenal insufficiency doses, low doses, but the high doses, including steroid injections, injections to the knee, joint injections to the back, etc. Sometimes patients don't know that those things actually contain steroids, and find out, is it reversible? Because if it's reversible, maybe you can hold back from starting insulin. But if you're seeing the patient and their fasting blood sugars are over 250, that would be severe hyperglycemia. For me, a fasting blood sugar over 180 is red flag, even over 150. But if it's over 250, hard that's going to be that you can just sit on that and see what happens. So you want to start insulin with basal insulin. Okay, you also want to see that that the patient has at least tried insulin sensitizers. I want the patient on metformin. Metformin is cheap, it's available, is every insurance covers that. There's no excuse for not taking metformin unless you have renal insufficiency and therefore it's contraindicated, or you have some other condition, maybe take a certain medication that where it interacts with it, or they have a lot of gastrointestinal issues, in which case I try to use extended release metformin. I'm a big fan of metformin, and I like to answer all the misperceptions that patients have about metformin, the weird commercials that they listen to, and I want to know what biases they have against metformin. If they don't want to take it, that's okay. I just want to hear it out and also explain to them why it might benefit them. But also it is a medication that has a lot of side effects, so they may not be able to take it. But if not metformin, then a GLP-1 analog, and I generally like to use combinations. So I want to have as many insulin sensitizers, or what I call insulin helpers, on board when starting insulin, if at all possible. Now, usually I would have already tried all those things. By themselves, they failed. And now I'm going to be adding insulin. Now, usually I'm going to be adding insulin. I'm not going to be saying, okay, you know what, all these other drugs, I'm going to throw them out the window, and we're going to do insulin only. I hardly ever do that unless it is a situation where the patient has severe side effects to the oral agents, or they turn out to be type 1. Based on the C-peptide check, and also the antibodies supported the type 1 diagnosis, and I already know this is going to be a type 1 patient, forget the oral agents or the non-insulin agents, and now I'm thinking along another lane. But other than that, I want to supplement their regimen with insulin. Generally, you want to start with 0.2 units per kilo, okay? Many times I start higher than that, because I'm seeing, how bad things are, and I don't want to take things too slow, because I know the glucotoxicity is very real and a big problem. But 0.2 units per kilo is a standard for starting basal insulin. You can do once a day, twice a day, whatever is more practical. You want to do what's practical, as the patient is actually going to agree to do. You don't have to stop the sulfonylurea. In fact, the sulfonylurea is more of a meal-related helper insulin. Because it causes secretion of the beta cells, and it's good to have, if you have to, use sulfonylurea with breakfast and dinner, along with basal insulin, along with insulin sensitizers like metformin, GLP-1s, etc. If the patient is on SGLT2 inhibitors, let me not forget those. Those are super helpful if the patient, again, tolerates it. There are other agents that are not going to be that helpful, like DPP-4 inhibitors. You can do what I like about the DPP-4 inhibitors, Januvia, is that they have very little side effects. So if they have issues with the other agents, you can do basal insulin and a DPP-4 inhibitor. Now, when you get to the point that they're taking basal insulin at a rate of 0.5 unit per kilo, and they're still not well controlled, at that point you probably need to add pre-meal insulin, and that's kind of a struggle for me. Starting basal insulin is easy to convince them. Look, it's just one injection. The needles are small. They don't hurt. I mean, you put the insulin pen at the bedside. You take it when you wake up, or you take it before you go to bed, or both. But it's easy because you can put it at the bedside. You can put it, somewhere practical. The pre-meal insulin, you have to stop and think about it every time you eat. So that one is more challenging to start. But by the time you start that, the patient has been on basal insulin for some time, and hopefully you have encouraged them to check finger stick blood sugars, and they're seeing for themselves what's working and what's not working. Of course, they have already been through diabetes education. You've already had the diet talk repeatedly, and they are learning as they go. They're observing what the diet does to their blood sugars. So by the time they need pre-meal insulin, they have learned a lot. And usually they're ready for it. I mean, they're not excited about it, but they're ready for it. And hopefully they have already made behavioral changes, and they know that this is the next step. The pre-meal insulin, I like to start with correction scale. Others like to start with standard pre-meal dosing. Either way, you must be careful to teach patients about hypoglycemia reactions. Because of the fear of hypoglycemia, that's why I like to start with a correction scale, meaning that you take pre-meal insulin only when the blood sugar is above a certain level, like the blood sugar is above 150. And you start pre-meal insulin 1 unit per 25 points over 150, and that way you don't let the blood sugar get too high, but also you avoid hypoglycemias because you're not giving pre-meal insulin when the blood sugar is lower, and then maybe they have a very high protein meal and not that many carbs. So eventually you want to teach the patient about carbs. All along the way they should be learning about carb counting and not eating processed carbs. At this point, the patient should already be going to diabetes education, honestly. And by the time you're thinking or have already started pre-meal insulin, you probably should refer them. And of course, if you're already starting basal insulin and thinking about starting basal insulin, that could be a patient that you want to refer as well. It depends. It depends how practical it's going to be for the patient. If you're going to start basal insulin and that A1C comes down, the blood sugars come down quickly, and you adjust the basal insulin to target the fasting blood sugar under 120, and the patient does it successfully, you don't have to refer that patient. In fact, many times you're going to see that patient a few times and send them back to primary care. But it's the more challenging cases that you really are going to want to refer, that are going to end up seeing endocrinologists on a routine basis, probably for the rest of their lives. And certainly if you get a patient that is masquerading as a type 2 and you discover, oh wow, they're type 1, look at this, look at these labs, then those patients definitely need to be referred, and they may end up using an insulin pump. And now, of course, if you feel totally comfortable dealing with this, you don't have to refer, but usually those are the type of patients that end up getting referred to us. Many times you resolve the glucotoxicity, that was what the problem was, and the patients may end up coming off insulin. They may get bariatric surgery, they may go on a very strict diet, they may go to diabetes education, start a new exercise program. This is reversible in many, many cases. And I have been surprised because sometimes I look at certain patients that have been on insulin for many, many years, and I'm thinking there's no way they're going to reverse this unless they have bariatric surgery, and yet sometimes they do. Always tell the patient that they have the ability to make things better. Now, I don't make a promise, oh, you can come off all insulin. I don't like to make those promises because sometimes people do everything that they can and beyond what you could imagine that they do, and yet they stay on insulin, and I don't want to set them up for feeling bad about themselves or feeling like failures, but it is possible to come off insulin once you start it, okay? So there's always hope for a type 2 diabetic, especially if the diet is bad, especially if they don't exercise. If they should start exercising every morning and following a recommended diet, it could be wonderful, okay? So even if it's not reversible and they're still gonna require insulin, having good lifestyle is always one of the top things that they have to do, okay? So if you have any questions, you can email msandrin@srhs.com, or you can call the office 864-560-6419 and leave me a message and I will call you back. I have a mobile phone that you can obtain from the operator. You can call me to my mobile phone, and I'll be happy to give you my mobile phone if you email me. any questions or email me through Epic. Okay, I hope I answered your questions. If I didn't think of something, I'm sorry, but just call me and I'll answer whatever question you have. Okay, thank you so much.